A joint inquiry into the lessons that can be learned from the response to the COVID pandemic, and in particular, lessons that can inform further decisions yet to come. And we conclude our oral evidence sessions today with the Secretary of State for Health, Matt Hancock. Pleased to welcome the Secretary of State. As in our last hearing, Jeremy Hunt and I will alternate in the chair, covering four themes. The first is the initial response to the pandemic. The second are the lockdown measures, the non-pharmaceutical interventions, as they're so called, and the test and trace system. The third is the development of vaccines. And the fourth, decisions taken in the autumn and winter of 2020-2021 and current policy issues. We'll pause briefly between these sessions to change over in the chair. Now, we took oral evidence from the Prime Minister's former advisor Dominic Cummings on the 26th of May. Mr. Cummings agreed at the hearing to provide written evidence to substantiate various verbal claims that were made at that hearing. Mr. Cummings was asked to provide this evidence to the committee by Friday, the 4th of June, in good time to inform our questions today to the Secretary of State. We have not received that evidence, nor any explanation as to why that has not been available. Now, as Jeremy Hunt and I both said in our last hearing, it's important that if serious allegations are made against an individual, they should be corroborated with evidence, and it must be counted as unproven without it. Now, most of this hearing will be about learning lessons, but I think it's only fair to the Secretary of State for him to be able to have his say about the allegations that have been made against him. So I'm going to begin with some questions drawing on those accusations that have been made. And I want to stress that these are suggestions and allegations that Dominic Cummings has made. They're not the committee's charges to investigate. So the first is, did you ever say anything to the Prime Minister that you knew not to be true?
No.
Thank you. And specifically, in terms of the particular points that Dominic Cummings raised, first, did you say that everyone who needed treatment got the treatment that they required when you'd been told by the Chief Scientific Advisor and the Chief Medical Officer that people did not get the treatment that they deserved?
I did absolutely say, both in private and in public, that everybody got the COVID treatment that they needed. And I'm very proud of the fact that with the NHS, we delivered on that during the pandemic because it was critical. There was no point at which I was advised, and I've taken the trouble to check with the Chief Medical Officer and the Chief Scientific Advisor, there was no point at which I was advised that people were not getting the treatment they needed. On the contrary, one of the things that we succeeded in doing through the entire response to this pandemic has been to protect the NHS so that people have always had access to treatment for COVID.
Thank you. The second allegation that was made was that on PPE, personal protective equipment, in April, did you ever say or brief that the shortages, such as they were the fault of Simon Stevens, the fault of the Chancellor of the Exchequer? It's not my fault. They blocked approvals. That's what Mr. Cummings told the committee. Is that true?
No, that is not a fair recollection of the situation. Now, getting hold of PPE was always a huge challenge. And as the National Audit Office have shown in their report into this, when they went through all of the details, there was never a point at which NHS providers couldn't get access to PPE. But there were huge challenges. We first opened the stockpile of PPE that we had in the event of a pandemic. We opened that in January. We started buying new PPE in February. In March, China brought in export restrictions. And you'll remember at the time that there was a huge global demand for PPE. There were aeroplanes that were being turned around mid-flight. The European Union put out demands for PPE, calls for PPE that went entirely unanswered. We had to remove a piece of bureaucracy that was in the way that put a limit on the price that could be paid for PPE. And we took a policy decision that we should pay at the top of the market. That did require the Treasury to make that change. The Chancellor was incredibly helpful in driving that through. And we managed to get to this position where, despite local challenges, and I don't deny at all there were challenges in individual areas, there was never a national shortage of PPE because of the action that we took.
Thank you. We'll come into more detail on that, but let me just check that I've understood correctly what you're saying. You were saying that there were blockages to the procurement of PPE. You requested, you objected to them, and you requested that they should be removed, and they were removed as a result of that.
That's correct. And also, I'll say this, I take and took and have taken throughout full responsibility for all of the areas that I'm responsible for. So the Chancellor played his part in resolving those blockages and getting them out of the way so we could buy PPE. And Sir Simon Stevens has worked incredibly hard throughout this crisis. My whole approach has been that this is a team effort. You can't respond to a pandemic just by pointing fingers. You have to respond to a pandemic by bringing people together, trying to provide that leadership, by having a positive attitude to teamwork, because that's the only way through it.
Were you aware that Mr. Cummings then said that there was an investigation into whether there were blockages, and he alleges that investigation by the Cabinet Secretary concluded that there weren't?
Well, I can't recall that, but what I can recall, and I know for a fact, is that there was a cap on the price paid for PPE. Because the global price had shot up, we had to remove that cap. I requested its removal. It was removed. And after that, combined with bringing Lord Dighton in, who did a brilliant job in this area, we could buy PPE more easily. And we're now in the happy position where we've got huge amounts of PPE, and 70% of it, other than gloves, 70% of it is made onshore here in the UK.
But who was responsible for that cap?
Well, you'll have to go through the records, but that was a condition on the budget that we had for PPE. So it was set somewhere within the machine. I think it was a Treasury condition, which is why I went to the Chancellor. But I am pretty sure that the Chancellor was not aware of it until I raised it with him, because the moment I raised it with him, with the Prime Minister, he got into action and he got it removed.
So it was a Treasury condition, a Treasury block on your department. So you didn't have the unilateral authority to
no, but I'm not blaming the Treasury. It's
wanted.
absolutely standard practice that the Treasury puts in place conditions when you're given a big budget. We were given a multi-billion-pound budget for buying PPE. On the 11th of April, one of the conditions of that budget was that there was a cap put on the price that we paid. The problem is that that cap was set in terms of the market price, but the market moved upwards massively. So we had to remove that particular piece of bureaucracy. I asked the Chancellor to remove it, and he did very rapidly. And then we could buy at the top of the market, which was one of the reasons that we managed to resolve the challenges of getting PPE into the country.
Absolutely. To be clear, I'm just trying to establish the facts, given the allegation that was made, and given that this is a lessons learned inquiry. It may be that the fact that you've had to change procurement policy may be a lesson for a response to an emergency. So it's an important point. And the third charge that Dominic Cummings specifically made orally against you was around testing in care homes. So specifically, did you tell the Prime Minister in March that people in hospitals would be tested before they went back into care homes?
We set out a policy that people would be tested when tests were available. And then I set about building the testing capacity to be able to deliver on that. We can go through it in more detail, and perhaps we will, the reasons for the clinical advice. So the clinical advice set out 3 different reasons why we took the approach that we did. And on care home policy throughout, we followed the clinical advice. And the challenge was not just that we didn't have the testing capacity, but also that the clinical advice was that a test on somebody who didn't have any symptoms could easily return a false negative and therefore give false assurance that that person didn't have the disease. That was the clinical advice. At the same time, the clinicians were worried, because it took 4 days to turn a test around, that if you leave somebody in hospital in those 4 days, they might catch COVID and therefore go back to a care home with a negative test result, but having caught it. And so the advice was the most important thing was infection prevention control in care homes. And the evidence has shown that the strongest route of the virus into care homes, unfortunately, is community transmission. And so it was staff testing that was the most important thing for keeping people safe in care homes. And obviously, again, for that, we needed the testing capacity. So those are the reasons for the decisions that were taken. That's the clinical advice that we received. We accepted this clinical advice. But in relation to what I told the Prime Minister, of course, the relationship between the Secretary of State and the Prime Minister is often that I make commitments to do things, I get on and do them, and then they're delivered. That's how the relationship works, as you probably know.
Indeed. So we'll come on, as you anticipated, in some more detail in the second section of this morning's evidence. But you've been very clear in your answer that what you told the Prime Minister was that people would be tested on discharge from hospital when tests were available. That was always clear in terms of what you said, and as far as you know, what was understood by the Prime Minister and others in Downing Street.
Well, I just take you to actually it's worth going to the precise language of the testimony that you were referring to, because that is in fact what was said, that people would be tested, and my job was to build that testing capacity, and with the team, we absolutely did.
I understand. We'll, as I say, come into the policy questions and lessons learned during the rest of this morning. I wanted to get your response to those charges that were made. Is there anything you want to add as a right of reply to the oral evidence that you heard from Dominic Cummings?
Well, it is telling that no evidence has been provided yet, but there's a reason for that, I think, which is that, throughout this, I have got out of bed every morning with the view and the attitude that my job is to do everything I could to protect lives and to get this country out of the pandemic. And I've approached that with a mission-driven determination to make it happen. And I've tried to do that with an approach of honesty and integrity, and critically answering questions both in public and in private to the best of my ability. Now, sometimes you have to say you don't know, because we're operating in a world where there's huge judgments being made with very imperfect information, often at great pace. But from the approach I've taken, not least in public and to Parliament and select committees like this one, and in private to the Prime Minister and everybody else, has been to be direct sometimes, yes, and I can be quite forceful when I'm trying to get something through if it needs to happen. But that's what you have to do. And crucially, you have to bring the team with you. There are a lot of people operating, doing the biggest job that they'd ever done in their lives. And you have to build confidence that people can go ahead and do what needs to be done. And then they're going to be supported in the judgments that they take. So we'll go through, no doubt, lots of difficult judgments that were made. And it's very important that we learn the lessons of which of those judgments could have been improved. And indeed, like on care homes, we did manage to improve the system over time. But the attitude and the approach was always to be direct and as straightforward and honest as possible. So in a way, I welcome this opportunity to tell you the truth of what happened, given the discussion that there's been over the past couple of weeks.
Given that discussion, why do you think it was that Dominic Cummings chose to be quite so withering? Did you have a bad personal engagement over the times? Was it a sincere difference of policy view, whether policies or, as it were, sort of operational decisions? What's the origin of this dispute?
I have no idea. I mean, I just I worked directly with the Prime Minister from the start of this. And of course, I worked with his aides and his team as well. And I have no idea.
Did you know that he wanted the Prime Minister to fire you?
Yes, because he briefed the newspapers at the time.
Right.
Or somebody briefed the newspapers. I now have a better idea of who it was.
And did you raise an objection to that?
Yes, of course. And I had the Prime Minister's wholesome support all the way through.
And was that problematic in your discharge of your duties in Whitehall, that this was happening in the newspapers, in the public prints, but also reflecting discussions that were taking place in Downing Street?
Well, I think the best thing to say about this, and this will be corroborated by lots of people in government, the best thing to say is that government has operated better over the past 6 months.
I'll turn to Jeremy Hunt for the first series of questions.
Thank you. Now this inquiry is about lessons learned for the future. So I just want to look in a bit of detail about the scientific advice that you received at the early stages of the pandemic. Test and trace is a very established key plank of our response now. But the original 4-point plan that was announced on the 13th of February last year, contain, delay, research, mitigate, said that community testing should be stopped after stage 1. That's what happened 3 weeks later on March the 9th. In South Korea and Taiwan, we now know, test and trace was used right the way through the pandemic, and as it progressed, they scaled up their testing rather than scaled it down. So my first question is, when was the first time that you, as Secretary of State, were advised that South Korean-style test and trace was a potential option for controlling the pandemic in the UK?
Well, I will answer that, but just before I answer the direct question, I want to correct something in the question, which is that testing was at no point scaled down. On the contrary, we were driving up testing capacity all the way through. And if you look at the record of the testing numbers, we spent January devising the test.
I understand that, but community testing was stopped. That was the announcement that was made in Downing Street on March the 9th. So there was still testing going on in hospitals and some in care homes, but the community element, which is what carried on in South Korea and Taiwan and other places,
yes,
it was part of the strategy to stop that. And I'm just wondering at what point you were advised that that different approach could be a sensible option for the UK.
Well, I thought that it could be a sensible option throughout, and this is what I was explaining. We were ramping up testing capacity all the way through. And at first, in January, PHE devised the test. We were one of the first countries in the world to devise an effective test. And then in February, we got that test up and running in practice, and we got to about 2,000 tests a day by the end of February. And then we multiplied that by 5 times over March. And in the middle of March, I took personal authority over the driving up of testing because it wasn't going fast enough. And what I'd say is that at the time, PHE were brilliant at the science and at the development, but simply hadn't had the experience or the capacity to scale. Now, this is important because what happened was that the growth in the demand for the tests for people who were symptomatic happened exponentially, whereas the growth in the testing, although very rapid, was in a straight line. And this meant that we had to prioritize the testing.
Yeah, I understand that argument. I'm really trying to talk about the advice you received. Now,
sure.
Dr. Jenny Harris was very clear. She said community testing was not an appropriate intervention. And she said that was the scientific advice that had been around for several weeks. Let's just have a look, because I really want to look at the exact evidence. The week before the big national lockdown was announced on the 23rd of March, Imperial published a paper, which was the modelling that they had done. And they had 2 options in that. One was what they called suppression, which was effectively a lockdown approach. Yeah. And the other was what they called mitigation, which was effectively allowing the virus to spread, but protecting the most vulnerable people. So there was no South Korean test and trace option in that paper. It was either lockdown or let the virus spread.
Well, there is no country in the world that uses only testing and doesn't have some form of lockdown as well. And so absolutely what I was up
But there
for.
is South Korea. South Korea has not had a lockdown. And that's the question. This is really what I want to ask you. Why were you not advised that that middle way, which would involve not stopping community testing as we announced on March the 9th, but actually expanding community testing, you weren't advised that in the run up to the first lockdown as an option?
Well, I wasn't, but I'm also trying to explain that I think there's a couple of points in the premise of your question that are wrong. So the first is about capacity. Unlike other countries, we did not go into this with a testing capacity. So one of the reasons that we had to reduce the use of community testing is because we didn't have a big enough capacity and we had to target the testing at where it's clinically most needed. The second point, which is really important here, is that the clinical advice I received was that testing people asymptomatically would lead to false negatives. And in fact, there was a SAGE decision on this, SAGE advice, on the 28th of January, saying that it would not be useful to test asymptomatic individuals. That advice was later changed. And in fact, maybe we can come on to a wider discussion about asymptomatic transmission, because that is a very, very significant part of what we have learned. So the problem was, we were advised you shouldn't test people without symptoms because you will get a set of false negative results. And secondly, that when you only have a relatively small testing capacity compared to, say, Germany or South Korea, you have to target it at the people for whom it might be life-saving. So that's the basis on which I understand.
I'm not questioning that you followed the clinical and scientific advice. I accept that.
Yeah.
I'm trying to understand what that advice was. And SAGE didn't model South Korean test and trace until April. They didn't actually discuss its impact until May. So I can't see any evidence in the papers that you or the Prime Minister were offered that South Korean style approach as an option at that first stage before the first lockdown was announced. I just want to check that is correct.
That is my recollection, yes.
Okay, thank you. Now, we didn't know at the time, and a lot of this is Captain Hindsight, and but it's important to learn from Captain Hindsight because we might have pandemics in the future. We didn't know at the time that Korea and Taiwan were going to have some of the lowest death rates in the world. But we did know that Taiwan had experience of SARS, and Korea had experience of MERS.
Yeah.
And being nearer China, they both had the pandemic, cases of the pandemic, before we did. So why do you think it took until May for SAGE to discuss the approach taken in Korea and Taiwan?
I don't know.
Okay. Well, let's just look at someone else that was a bit closer to us, who was also talking about the same kind of thing, which is Dr. Tedros at the World Health Organization. So he said on the 16th of March, so this is before our first lockdown, that test and trace needed to be escalated.
Yeah.
At that time, Taiwan, Australia, New Zealand, Korea, they'd already started closing their borders.
Yeah.
They'd all kept their cases to below 2% of the population.
Yeah.
Do you think we had a blind spot about what was happening in East Asia at that time? Because there doesn't seem to be any evidence that it was fully considered.
I think that there are a significant number of lessons from this. One is that the need for a rapidly scalable testing operation must be part of pandemic preparedness, and this country did not have one. And if you think about the areas where we were strong in our response to the pandemic, there are areas where we had prior strengths. So the NHS response was very strong, built new hospitals, delivered care to everybody who needed it. The science response was very strong. You know, we have a centuries-long science tradition. We didn't have a major diagnostics industry or capability. And the tracing and isolation system was essentially built for very important but very small outbreaks. You know, as health secretary, you're dealing with these sorts of outbreaks all the time. I'm currently dealing with a monkeypox outbreak and an outbreak of and cases of drug-resistant TB, and that is absolutely standard. And the lack of that capability at the start meant that the options that we had were fewer.
But let's just look at what you did in April very successfully, which was ramp up testing capacity to 100,000 a day. That was a big change.
Yeah.
If you had been advised in January or February, we're going to need more testing capacity if we want to go South Korea.
So I don't think that's...
And let's start this right away.
But we did. So we did. In January, I was driving the system to drive up testing capacity. In fact, in preparation for this meeting, I was looking at the minutes of one of our internal meetings on the 27th of January when I was calling for the driving up of testing capacity. And PHE's response was excellent on the science, but there was simply not the experience to drive up capacity. And so when we got to 2,000 a day by the end of February, and it was still rising, but by the middle of March, it was not rising fast enough. We were not doing enough to bring in the private sector capacity. So I took personal charge of it. And then a couple of weeks later, set the 100,000 target. And that 100,000 target was essential in galvanizing the whole system and building a diagnostics organization and ecosystem in this country. And now we do about 6 million tests.
And that was a very important step in our pandemic response. But the strategy at the time was clear that when we got through stage 1, community testing would stop. Now, on the 16th of March, when Dr. Tedros said we needed to test, the week after we'd stopped community testing, did you challenge officials and say, why do we appear to be doing something that is completely different to what the World Health Organization is advising?
I entirely agree with Dr. Tedros at that point. And the challenge, though, was the scale of the capacity. And I'd driven that as hard as I could within PHE with my indirect, therefore, hands on the levers. And then in the middle of March, we had a meeting. I remember it very clearly. We had a meeting in Downing Street at which we had an array of the test providers. We had the PHE team who were doing that, the testing, and I took personal charge of the testing project.
I know you wanted to expand the capacity. I'm just trying to understand the strategy.
Yeah.
So you confirmed that you weren't offered South Korean style test and trace as an option.
As far as I can remember.
In the run up to the 23rd of March. Did you ever ask SAGE to analyse what was going on and do the modelling for
Yes, and in fact,
for South Korean style test and trace?
Yes, and I had calls with the South Korean ministers myself in order to understand what they were doing. So why did that modelling not happen until April, and why were there no discussions till May? Because this would have been a big emergency. Essentially because of a lack of capacity.
No, I'm talking about discussions in SAGE. I understand the lack of capacity was a problem, but in terms of the strategy, SAGE didn't discuss this until May. If you requested them to look at it earlier, why did it take that time?
Well, I'm not sure that I did directly. What I was doing was asking around the world for who's got the best response. But all of these questions are predicated on the idea that we simply could have had more tests. We couldn't. I drove the system as hard as I could, including having to go in and essentially become, take executive authority over delivering it. And then we brought in Dido to pick that up because it was such an enormous task.
Okay, I just need to ask you one question similar to what Greg asked you about Dominic Cummings' allegations, which again, we have to stress he didn't substantiate when we asked him to, but I do want to give you a chance to comment on the record. He said that you used the whole "we are following the science" line as a way that meant that you could always say, well, if things go wrong, we'll blame the scientists and it's not my fault. And he said he saw you discuss that with the Prime Minister. Is that true?
I don't think so, no. And I'll tell you why. And we've discussed it at the Select Committee before. My approach throughout has been that we are guided by the science. I try not to say that we follow the science. There are examples where ministers make decisions different to the scientific advice. One example is that when we brought back people from Wuhan, in January, I was advised that they should be asked to go home and isolate. And I said, no, they need to quarantine. And we used the NHS facility at Arrow Park on Merseyside, you'll remember, and we took people directly from the planes and put them in Arrow Park and made sure that they were quarantined. Now, that is an example of the scientific advice saying you can be more relaxed about things and me being tougher. Now, when it comes to the decisions around lockdown, we did accept and implement the scientific advice, and I'm sure we'll come on to that, those particular, the early March period. But I take full responsibility for the decisions that not only that I take, but that are taken in my name as Secretary of State across the health family and the NHS, Public Health England, in the department. And I know the Prime Minister feels very strongly the same, but of course you're guided by the science.
So just looking forward, my last question on this area, how do we improve the quality and the diversity of the advice going to ministers from SAGE and the scientists in the future? Do you think there would be merit, for example, in a pandemic situation rather than normal times, in publishing that advice immediately so that you get the benefit of instant peer review from the entire scientific community?
Yes, and now thankfully we do publish the evidence now and the minutes of those meetings. And I think that the public debate around this is generally healthy.
Thank you.
Thank you. Just in terms of following up Jeremy's question about career, the Science and Technology Committee in March took evidence from Public Health England, and one of the officials there said an evaluation had been made, a formal evaluation of the South Korean model as to whether we could learn lessons from it in that early phase of the pandemic. But try as we might, that paper seemed to have evaporated, it disappeared. It's never been produced to us. Did you ever see it?
I have no recollection of that. That's not to say no, because actually in prepping for this committee, I've gone through a whole load of this, and there's some things I've discovered that I'd forgotten that I did. And so it's not a no, but I have no recollection.
All right. And just on the 100,000 target that you set when you'd gripped the problems that you saw. That was the subject of again some quite bitter criticism from Dominic Cummings. He said it was criminal that you should have set that target, and it was notable during that time. Again, the Science and Technology Committee took evidence, and no one that came before us, including your officials, wanted to associate themselves with the target. Even your testing czar, John Newton, where we asked him what was the derivation of the 100,000, said we'd have to ask the Secretary of State, it was his target.
It was my target.
So, but evidently, why was it the case that even your advisors and the whole of Whitehall seemed to be running away from it and not wanting to associate themselves with it?
Well, I think after we hit the target. Before, well, there you go. So
just explain what's in your mind there.
Well, we didn't know we were going to hit it, and sometimes you have to put yourself in jeopardy. You put yourself on the line, and in this case, I knew we needed a radical increase in the testing capacity, a radical increase, and the incremental increases would not do. And so I set the 100,000 target, and I set it on the advice of my team who were doing the ramp up. I asked them what's the best they could do by the end of the month. The advice they gave me was just over 100,000, but 100,000 is a good number for a big target. And the purpose of the target was to galvanize the system, and it worked. And if you ask anybody involved, including many of those who've been mentioned during this select committee process, they will say that the 100,000 target mattered because it galvanized the system, not just in the government, but the whole country. We needed diagnostics companies to come to the table. We needed the NHS labs to step up further and expand. And it said to everybody, we are going for it big time. And it worked. Now, within government, the whole of the department, involved in testing was focused on the goal, and I'm delighted to say that we hit it. Now, there were others. It turns out I had no idea at the time that there were others who were who were not as supportive as I might have hoped.
You didn't know that Dominic Cummings, for example, at number 10,
I knew that
as far as he spoke for them, was against the whole enterprise of 100,000.
I was a bit surprised by the testimony that that he didn't think that we should have a target, or that we shouldn't. Anyway, I was a bit surprised.
But you didn't know
by
at the time. That hadn't been communicated to you at the time.
No, and I'll tell you why. Because what I was just coming on to, the Prime Minister was absolutely foursquare behind me and gave me his full, wholehearted support in hitting the target. Because he, like me, knew that we needed a radical increase in testing, and it is a tried and tested method. In fact, it turned out afterwards, I was told that this is an absolutely standard business school methodology. I've never been to business school, but it turns out, you set a big goal, you galvanize the team, you give everybody confidence just to do what is needed to build this capacity, and it worked. And I also saw some testimony from some people saying, we needed to get to a higher number. Well, absolutely, but you can't get to a higher number without going through the lower number first, and this is what we did.
Okay. Laura Shott.
Thank you, Chair. Dominic Cummings said on the 25th of January that he contacted you about pandemic preparedness, and you said to him, "We've got 4 plans up to and including pandemic levels regularly prepped and refreshed, CMOs and epidemiologists. We are stress testing now. It is our top tier risk register." Is that your recollection of what you said? And with hindsight, what are your thoughts on the level of pandemic preparedness that was in place at that time?
Yes, I think the record is actually slightly wrong, because I said, well, that's all correct, except I said the CMO is an epidemiologist.
Okay.
But the question was, are we ready for something like Ebola or a flu pandemic? And famously, the preparations and the plans that were in place were for a flu pandemic. Now, the honest truth is that this was a completely novel virus. And in fact, as we'll come to when we talk about asymptomatic transmission, it's different even from the previous coronaviruses, including SARS and MERS. So it's true that the countries that experienced SARS and MERS were better prepared than we were, partly because of that experience. But it is also true that COVID-19 is very different from SARS and MERS, and the number one difference is that it has asymptomatic transmission. So those plans that were in place, the flu preparedness plans, they were incredibly useful in some areas. They meant that we had a draft bill, which became the Coronavirus Act. It meant that we had plans ready for infection prevention and control. And in fact, we published our first infection prevention control data and guidance, guidance, on the 10th of January. So those plans were important. But of course, when you have a novel pathogen, it behaves differently to what any plans could possibly set out. And what really mattered is the capabilities that we had. And there were some areas where we had strong capabilities, as I said to the chair a moment ago. There's some areas like the NHS, like science, where we had strong capabilities. There's other areas where we had weak capabilities, especially testing. And also on a vaccine, that's a big difference with flu preparedness, because we had vaccines ready to go on flu, and we've got antivirals. We've still got a big stock of them. But for a coronavirus, there was no vaccine, and there aren't any proven antivirals either. So what I said is absolutely true in response to the question. He asked me, are we ready for Ebola or a flu pandemic? And I said, we have full plans for those things. But of course, at that time, 25th of January, in the department, we were working incredibly hard on responding, not just to Ebola or a flu pandemic, but responding to what we knew of what became COVID-19.
And how many of those deficiencies were predictable? So do you think we should have learnt more from SARS and MERS? And do you think that the lack of diagnostic testing was a predictable failure that we should have addressed pre-pandemic?
It's a very good question. Some of these things we would have done better to have learned from SARS and MERS. Other things weren't predictable. So, for instance, I first asked for started the push for a vaccine in January. And in fact, I had a meeting on the 25th of January pushing for a vaccine, in which I was told that it would take a long time, that it would take normally 5 years, and typically if we accelerated everything and if everything went right, it would take a year to 18 months. And I said, I want one within a year, and we will throw the full resources of the state at making that happen. And we tasked Jonathan Van Tam with leading that project, and it was obviously hugely successful. Now, so it was predictable that we didn't have a vaccine for a coronavirus. And so as soon as we knew this was a coronavirus, which was relatively early in January, we knew that the gap in the vaccine armory would be a significant gap. There's other things that were far harder to predict.
And in terms of, if you think about the function for pandemic preparedness, if we're trying to make changes in the future,
Yes.
do you have any reflections on things that we should do to make sure
Yes.
those predictable deficits are fixed for next year?
Absolutely. So we need a standing testing capacity so that we can stand it up immediately. We need an at-scale contact tracing capacity so that we can contact trace even when the numbers get big. Because the reason that community contact tracing stopped was because the number of infections was so big, and the capacity, again, as with the other PHE capacities on the way into this, were great on the science and small scale, but couldn't scale. So we need in good times to retain a capacity so that as and when a new pathogen hits that could become a pandemic, we are ready to pounce on it. I think another huge learning point is borders. I don't know whether we'll come on to that later, but on borders, the position that we took was based not just on World Health Organization advice, but on their international health regulations, which stipulate that closing borders is not an appropriate response in a pandemic. That is the international regulation. Now, the advice that we received, the clinical advice we received, is that unilaterally taking action at the borders would only have a small effect in terms of delaying the response of about a week. And indeed, early in the pandemic, this was proven by both the United States and Italy taking direct action at the border, and they still had the disease went rife. But if everybody takes action on their borders and restricts movement, then clearly that can have a big impact. And so we've strengthened our border policy throughout, and now we have one of the strongest borders policy in the world. But my reflection on it at the time, and this is very important for the lessons learned, is that the only way the world could have stopped this virus getting out of China is if China itself had stopped people leaving China. Because as soon as people were allowed to leave China to go to one place, then unless the whole world took action on borders, as they have now, it would only have delayed to a degree. That was the clear clinical advice. And it is one of the things that we absolutely must change at the global level, that part of the response to a dangerous pathogen needs to be health action at the border.
Thank you, Secretary. Thank you, Chair.
Thank you. Rebecca Long-Bailey.
Thank you. Mr. Hancock, you've said that testing was at no point scaled down. You were ramping up testing capacity all the way through, and that you wanted to scale that up certainly in February, but that you had to prioritise testing. So just before the first lockdown, what was the plan for the prioritisation of testing?
Yes, this is important. I think it was published, but if not, I will write to the committee with the full clinical details. So this was a clinical document that set out the prioritisation according to what use of tests is most likely to save lives. And if I recall correctly, the top item was use of tests in intensive care, because in intensive care, if somebody has breathing difficulties, the difference between knowing that this is COVID-19 or not can be a life-saving difference. So if you start with intensive care and then work through, but it was a clinical prioritization.
A whistleblower reportedly stated to the media yesterday that in March 2020, Public Health England's internal advice was to ensure that any patients newly discharged into care homes had to be tested for COVID-19. Now, the whistleblower allegedly says that this initial advice was signed off by two PHE officials, Dr. Eamon Moore, Director of Health and Justice, and Dr. Julia Byrne, Head of Clinical Epidemiology, and that was the case up to the period just before the first lockdown. Would you say that was correct?
I have no recollection of that. That is not my recollection of the clinical advice, and I haven't seen anything on that.
Well, the whistleblower goes on to say that even though officials were fully aware of COVID-19 outbreaks in care homes at this time, allegedly one of your health ministers leaned on Public Health England to alter the advice being published because your department believed that they needed to empty space and get people out of hospitals. And the whistleblower says that Dr. O'More and Dr. Byrne were therefore pressured to sign off on published guidance that was softened to allow care homes more freedom to take residents in. So was discharge testing advice softened at the instruction of your department?
Not that I'm aware of. If I can set out the clinical advice that we were given, because we followed the clinical advice throughout on this, and it's a very, very important topic. And if you think about it, right from the start, we knew that people living in care homes were amongst the most vulnerable. And we did all that we could to support them. And we knew that because we know that COVID-19 has a bigger impact on people the older that they are. And so this was obviously a very important topic from the start. The clinical advice at the time had three parts. Firstly, that if you take somebody who's had a test, and given that it took about 4 days for the test result to come back, and they stayed in hospital, therefore, for those 4 days, that test could come back negative, but the person could have caught COVID in hospital in that time. And that's obviously bad for that individual, but it's also bad for the care home, because then they'd be going back to a care home with a negative test result, people thinking that they tested negative, but having COVID-19. Secondly, the biggest challenge in this space was that the clinical advice at the time was that if you didn't have symptoms and you took a test, then it was likely to give you a false negative result. And that clinical advice stayed all the way through this period and then was changed later. And then the third point is that the most important thing to do, which is what we did in the advice that we gave to care homes starting in February, is to make sure there's infection prevention and control in the care homes. And in fact, the data published since all of this has shown that the best estimate from Public Health England is that 1.6% of the transmission into care homes came through this route. And in fact, what that tells you is that, sadly, the biggest route of COVID-19 into care homes is through the community. It's through people who live in the community and work in the care home. And so the most important thing for protecting people in care homes was staff testing, which we introduced as soon as we had the testing capacity to be able to do so.
Well, certainly there seems to be a lot of confusion here as the allegations suggest that Public Health England advice was initially to test on discharge. And certainly, as we've heard, Mr. Cummings told this committee that number 10 had been specifically told that that was happening. So to clarify this, would you provide copies to this committee of all internal advice and communications between your department, Public Health England, and your ministerial team on hospital discharge and care home testing, certainly for the period from January to April?
I'm very happy to ensure that the clinical advice and the clinical testimony is provided to this committee. Yes, and in particular, if you actually look at the testimony to this committee about the commitments that I made, the commitment was that we would introduce this testing. And when we had the capacity to do that, given the other pressures on testing, which is a life-saving resource, we did that.
So just to be clear, you're happy to publish all clinical advice that PHE, your departments, and your responses and your ministerial team's written responses to the committee, so that we can analyse the same.
Well, I'm absolutely happy to provide the clinical advice on which these decisions were taken. Yes.
So not your responses, Mr. Hancock.
I'm sorry, I don't understand. This decision
Would
was.
you be prepared to publish your written responses to that advice and the written responses of your ministerial team, so that we can be clear on what direction public health officials were given?
Yes.
Thank you.
And just on that point that Rebecca Long-Bailey raised, so she mentions what Rebecca's described as initial advice at the beginning of the pandemic, just before lockdown, which is the period we're looking at in this section. And that was signed off by two PHE officials, we're told, Dr. Moore and Dr. Verne. Will you provide the committee with that initial advice?
Well, I don't know anything about that advice.
Well, assuming it exists.
So, but I'm very happy to go away and look to see what advice was given.
And assuming it exists, will you provide that initial advice to the committee so we can compare it to the advice that was eventually adopted?
Well, subject to the normal rules of disclosure. So I'm cautious here, but I've got a reason for it, which is that there is in that period there will have been a lot of advice written that then goes through layers of clinical approval, and there will have been. So I don't want junior officials to end up having their material put into the public domain. But what I'm very happy to do is go through and look, especially if there is particular advice from these named individuals, and to make sure that that's provided to the committee. Well,
as you said in answer to a question just a few moments ago, actually transparency about the process of decision making. Everyone was operating, especially in those early weeks, in a fog of great uncertainty as to what was the right thing to do.
Yeah.
We're trying to learn lessons that might be applied later in this pandemic, but to other emergencies as to what the right approach is. So what's obviously vital for that is not just to see the final products, but how the advice evolved.
Yes, and also the reasons for that evolution, because there will have been a debate about it, I imagine.
Precisely, exactly. So that I think is behind Rebecca's question. I think it's why it would be useful to see this.
Okay.
Thank you. Just in terms of those early weeks and talking about taking clinical advice and following scientific advice, as you say, one of the clear things that's emerged from our oral hearings and the evidence that we've had is that clearly we didn't lock down early enough. Neil Ferguson suggested quite a lot of lives would be saved. I think he said up to half of those initial deaths if we'd locked down a week earlier. The whole question of the changed advice in the middle of March reflected that. And again, this is something that I think has pretty clearly emerged. And some people said there was a degree of groupthink around this. From your position, did you not see that for all of the kind of complex modelling, that actually the mathematics of this pandemic were pretty stark? That you have, say, 60 million people in the adult population. If 2/3 of them contracted COVID, and 1% of those who contracted it died, we'd have 400,000 deaths, and that is unacceptable and liable to overwhelm the NHS. How did we, and you in particular, alongside everyone else, miss this for so long, for about 6 to 8 weeks?
Well, I would absolutely say that we knew about this problem from the start. And the challenge in those early weeks of March was making a massive judgment, probably the most significant judgment that any Prime Minister has made certainly in peacetime, based on incomplete information and at great pace. So I instructed the department and the health system to plan on the basis of a reasonable worst case scenario in January, in fact on the 27th of January. And and I asked for a reasonable worst case scenario planning assumption. And I was given the planning assumption based on Spanish flu, and it was signed off at Cobra on the 31st of January. And that was a planning assumption for 820,000 deaths. And I was determined that that would not happen on my watch. So throughout February, we were planning for how to stop that and how to deal with the consequences of if it came true. And in the middle of February, the scientific advice confirmed that the reasonable worst case scenario should be taken as read, that this was equivalent to Spanish flu. I mean, if you think about it, at the time, at the end of January, when that was first presented at Cobra, I, like everybody else, thought of Spanish flu as something you read about in the history books. But as health secretary, you're always worried about new pathogens, when we're dealing with them all the time. But knowing that that was the reasonable worst case scenario, we planned for it. And then we did the work in February, and on the 3rd of March, I set out to Parliament our, what we call the action plan, which set out all of the actions that we might have to take, up to and including shutting schools. I was asked about on the media about it, about lockdowns, and confirmed that we would be happy to take those. But at the time, on the 3rd of March, when we set that document out, setting out all the things we might have to do and saying that we were prepared to do them, there were no deaths. Indeed, on the 3rd of March, there were 50 cases. The week beginning the 9th of March, what happened is that the data started to follow the reasonable worst case scenario. And by the end of that week, the updated modelling showed that we were on track, essentially, on the track of that, something close to that reasonable worst case scenario. I think the numbers were slightly below that, but they were of a scale that was unconscionable. So we then, therefore, on the 16th of March, when there were 611 cases and 53 deaths, we took the decision, we announced that everybody in the country should stop all unnecessary social contact.
So we know what happened, and we've got a clear view. It's all in the public domain, but it's evident, and everyone agrees. Sir Patrick Vallance said it would have been better if we locked down earlier. Neil Ferguson, I mentioned, said that it would have a big reduction in deaths. We didn't do what was necessary early enough, and it seems to me that everyone, or certainly most people in the system, got bogged down in the modelling and the complexity, and didn't step back to see the crude maths of it, if you like, and to take the measures that were eventually imposed earlier. And in trying to learn lessons and thinking back, you were someone that was involved in all of those discussions. How was it that you, but everyone else, didn't see the enormity of what was going on and took these literally incremental decisions to turn up the dial progressively week by week in terms of restrictions? Why did we miss the big picture?
Well, the clear scientific advice at the time was that there is a need to have the tools like lockdown at your disposal, but also that the consequences and the costs of lockdown start immediately. And critically, the clear advice at the time was that there's only a limited period that people would put up with it, would put up with lockdown. And so now that proved to be wrong, because the British public have stepped up to what we've asked them to do in an extraordinary way.
So much of that proved to be wrong. It proved to be wrong that people would only tolerate the restrictions for a short period of time. It proved to be wrong that the level of infection could be contained within the NHS until that had to be revised. We're aware of that, and SAGE got it wrong. It's now very clear, and members of SAGE are candid enough in the scientific in the way of scientists to concede that, and this is what we're trying to learn.
Yeah.
Was it the case that you simply accepted that scientific consensus without challenge because that was their business? Were you concerned about it yourself, and did you challenge it, or did you think it was not your place to, you were there to enact what was being recommended?
No, we absolutely debated and challenged that advice. But when you're faced with a decision of this enormity, and ultimately, of course, as health secretary, my primary goal on protecting lives, finding a way out of this and protecting the NHS, I made that argument. But ultimately, we didn't know how long people would put up with it. And now it seems obvious that people would put up with lockdowns. It was not at all obvious. We needed the protections in place, especially for vulnerable people in the shielding program. We take for granted that has been a huge success, but that wasn't clear at the time because lots of people rely on social contact literally to live. And we needed to ensure that we could, for instance, support businesses to get through this. These are huge decisions. To take those decisions against the scientific advice is an even bigger decision to take. Now, when the scientific advice moved, then that became easier. And I remember when
do you regard it as part of your role to challenge that scientific advice, to debate it, to stress test it, to ask others perhaps around the world?
Yes, and of course. And I was discussing this with my counterparts across the world. And I've been willing to overrule the scientific advice earlier, for instance, on quarantine. I pushed in January for a wider flight ban from China, but the scientific advice was we should only restrict it to Wuhan. So absolutely, challenging the scientific advice is one thing, but overruling a scientific consensus is much harder, especially when the costs of the lockdown are immediate and are obvious. So I remember very, very clearly when the new projections from SPI-M came in towards the end of the week, beginning the 9th of March, and I can't remember exactly what day it was, but towards the end of that week, SPI-M came in with some new projections. And I remember going into number 10 and one of the most senior advisors saying to me, sort of ashen face, "Have you seen these new projections? Isn't this awful?" And I said, "I'm glad the projections are now showing what I think is happening, because the data, you've got to remember, let me take you back to what it was like. The data was so incomplete and sparse. Even getting data out of the hospital system was very difficult. And we now have infinitely better data systems.
So how did you form this view of what was happening?
Because I could see from what I was seeing on the ground, I could see from anecdotes from what I was hearing. You could see it in the testing data, the testing numbers going up. You could just see it in the number of people, sadly, who were dying, but the numbers were still very low at that stage. As I say, on the 16th,
and that's the advantage of being health secretary, that you're literally visiting hospitals, you're talking to people.
So then I remember the moment around the cabinet table when I said, we are going to have to tell everybody to stop all social contact.
Right.
And I remember thinking, this is the most extraordinary thing that I've ever said. And the Prime Minister said, yes, we are. You better go and tell them.
So as it turned out, what you just said there is pretty much identical to what Dominic Cummings told the committee, that he had come to believe that there was going to be a disaster and that the assumptions that policy was being based on were wrong, but that he felt intimidated. He didn't use that word, but what he said in multiple answers said that he felt very reluctant personally to intervene, to overturn what had been an established consensus. And that's, am I right in detecting in what you said a similar thought?
I just think it's hard when there is a clear scientific advice to go against that with a decision of such enormity. And there's one other example that I wanted to set out. Maybe now's the moment to do it, which is about asymptomatic transmission. So one of the big reasons that we changed policy, for instance, towards care homes in April, was because of the conclusion that there was significant asymptomatic transmission. Now, there was a global scientific consensus based on decades of expert work on coronaviruses that coronaviruses do not transmit from people who don't have symptoms. And this is wrong, but it's wrong because this is a novel pathogen. It's a novel virus. It's unprecedented. I heard evidence from China that there was asymptomatic transmission in January. And I also remember talking to my German opposite number, Jens Spahn, and they had seen some evidence in Germany. And I asked the scientists to look into this. And in fact, I was so worried about it, I arranged a call with the World Health Organization. And I was told on that call that with respect to China, this was likely a mistranslation.
When was that call that you made?
At the end of January. I can get the exact date.
You'll have a transcript of that.
We have a note of the meeting, yes, and I'm happy to supply that to the committee. I was told that it was likely a mistranslation. And after that, we did not get the evidence from China, which could have proved it. So I was in a situation of not having hard evidence that a global scientific consensus of decades was wrong, but having an instinct that it was. And I bitterly regret that I didn't overrule that scientific advice at the start and say we should proceed on the basis that there is asymptomatic transmission until we know that there isn't, rather than the other way around. But when you're faced with a global consensus and you don't have the evidence that you're right and this scientific consensus is wrong, it is hard to do that. And eventually, on the 2nd of April, the World Health Organization was still claiming that there was no evidence of asymptomatic transmission. It's the 2nd of April. Now, on the 3rd of April, the CDC came forward with an evidence paper, and very shortly afterwards, Public Health England came forward with a further one, and the consensus scientific position changed, and then we brought in the stronger. We changed a number of policies across government as a result. But that is a story of how how preparedness and relying on the science, which is normally the right thing to do, and let's be clear, we're picking on two areas where there was where it would have been better if the prevailing consensus at the time had been overruled, but everybody was operating on highly sketchy, just a lack of data and a lack of information because this is a novel virus.
Well, what you said about the difficulty of challenging a consensus, a scientific consensus, is very frank, and I think it's very helpful for us to reflect on. And we've heard from other people variations on that theme. But since you raised this question of asymptomatic transmission as not being known and knowable, you said you had an instinct, but the science was against it. It is the case, as you'll be aware, in the SAGE on the 28th of January, the second SAGE meeting, in the minutes, point 16, it says there is limited evidence of asymptomatic transmission, but early indications imply some is occurring.
Yes. So I raised the prospect of asymptomatic transmission on the 27th of January with the CMO and others. And he took it away and they discussed it at SAGE on the 28th. And I called the WHO on the 29th. And I've got the quote here. I was told that it is highly unlikely it was highly likely that the message may have been confused via translation issues, but that this is unclear.
Okay, but SAGE on the 28th of January concluded that early indications imply some asymptomatic transmission is occurring.
Yes, and the overall scientific...
So SAGE did not... So in the minutes of SAGE, it was not recorded as saying the consensus is that there's no asymptomatic transmission. Quite the opposite. They're saying early indications imply some is occurring.
But the the World Health Organization advice and the clinical advice that the most likely situation that I received remained that asymptomatic transmission was unlikely. And in fact, the WHO's position was that, and I quote, "There has been no documented asymptomatic transmission." Now, as I say, given all of this and this debate, and it's an absolutely accurate reflection of the debate, I regret that I should have stuck with my guns and said, well, there is, even if it's uncertain and even if it's relatively small, we should base policy on that. Because even though the advice, the formal advice I was receiving was that it is asymptomatic transmission is unlikely and we shouldn't base policy on it. And that was, and I should have overruled that.
Well, this is an important point, and you mentioned the WHO in that, and you said that the WHO view on the 2nd of April, I think you said, was that asymptomatic transmission was not to be assumed, was not a possibility. But in fact, the WHO on the 2nd of April, in its situation report, said, and I quote, "Transmission from a pre-symptomatic case can occur before symptom onset."
Yeah, and so we had this position where there was this essentially there were individual instances of the evidence being presented, but the overall scientific conclusion, which was the recommendation for the policy advice, was that it was highly unlikely there was asymptomatic transmission.
Well, that's a strange thing to conclude, because SAGE on the 28th of January said early indications imply some asymptomatic transmission. The WHO on the 2nd of April said for transmission can occur before symptom onset. So there certainly wasn't a consensus. There might have been mixed messages, but not a consensus.
Well, there was what I can tell you, and I can send you the details, is that the clear overall clinical advice was against this, despite the fact that that I raised it from the start, and there were individuals in the system who were pushing this argument, and there were individual conclusions. But if you look at the totality of the evidence, then this was the position. And as I say, I wish that we had that I stuck to my guns at the start.
Well, we'd be grateful for that advice, and it doesn't stand against your conclusion that, as you just said, it would have been better if we had assumed asymptomatic transmission, even to the point of you stepping in and overriding the assumptions that some other people were making. Just finally, and then we'll turn to the next theme of our questions. We heard, as I'm sure you've seen reported from Dominic Cummings, that during this period in mid-March, when the penny was dropping, that we were on the wrong track and needed to change, the Deputy Cabinet Secretary, Helen McNamara, came into number 10 Downing Street and, according to Mr. Cummings, said, "This country is heading for a disaster. I think we're going to kill thousands. There is no plan for this. We're in huge trouble." Was there a plan?
Yes, and at that point we had published it.
So Helen McNamara was wrong, or do you think she didn't say that?
I have absolutely no idea. But what I can tell you is that we published the action plan of the actions that we might need to take, including these extraordinary, unprecedented actions. And the question was when to make the judgment to do it, when to put in place, if it was needed, a lockdown, closure of the schools, etc.
And so Ms. McNamara or one of her colleagues hadn't communicated to you her concern that there was no plan?
I don't recall having any conversations with her at that time.
Or any of her team of officials?
Well,
to obviously you had a conversation, but to that effect, to raise the alarm that there was no plan.
I don't understand that testimony.
Okay. All right.
I also note that no evidence has yet been put forward for much of this testimony, and I find that telling.
Indeed, and it's part of the point of asking that question is to see whether your recollection tallies with what was said, or you've been clear about Well, that brings to the end this section of the hearing. I'm going to hand over to my co-chair, Jeremy Hunt. We'll suspend the sitting for about 5 minutes while we just change around.
Okay.
So order.
The proceeding is currently suspended. 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 The